Hi, and welcome to the third episode of Just Societies Live, the collaboration between the School of Social Work and the Columbia Just Societies Initiative. I'm Michael Friedman, the host of this and Social Work Live, and every week I have the great pleasure to talk to really interesting people from the Columbia community. Today I'm joined by Anindita Dasgupta, who is a postdoctoral fellow and a research scientist at the Columbia School of Social Work and one of the lead investigators of Aspire. You'll tell us what that is when we get to it. And also by Maya Sabatello, who's an assistant professor of clinical bioethics at the Department of Psychiatry in the School of Medicine. She's also an adjunct in the law school, so you're getting around here, right? And she's the co-director of a very interesting sounding project, Precision Medicine, Ethics, Politics, and Culture Project. So we're going to learn about that as well. I thought I'd start with Anindita to tell us what is Aspire.
Yeah. So thank you so much for having me. I'm excited for today's talk. So Aspire is an initiative here at the School of Social Work, and it's really designed to bring together our academic community around the Syrian refugee conflict. We have a number of aspects of this initiative. Of note, we have 2 recently completed research studies on Syrian refugee health, one in Jordan and one in Turkey. And we are very excited to share some of our brief descriptive findings of these studies, this week actually. So just a little plug that we have an event on April 25th. Thursday from 4 to 6 p.m. here at the School of Social Work. There will also be a live stream. And we're very excited because we have been able to bring 2 investigators, one from Jordan and one from Turkey, who have been instrumental and are partners.
Sounds interesting. How can people sign up?
There's an Eventbrite link, and I think it should be in the comments. So I hope people will join either in person or online.
Speaking of comments, I forgot to mention, we talk for about 15 minutes and then we take questions, and you can put your questions into the comments section and we'll pick them up later on. So we're going to come back and talk about what your findings have been for the refugees. It sounds really interesting. Maya, what is this? Precision medicine and the rest of it. What is that?
So, precision medicine is the new sort of effort to create a more tailored approach to healthcare. It is the idea that we will be at some point today or in the future be able to tailor health prevention, diagnosis, and medication to individuals according to individuals' genetics, environmental factors, and lifestyle choices. So that's a big national effort. Columbia University in particular is one of the lead universities in the country and probably in the world working on the precision medicine and precision medicine research. The project that I'm co-directing with my colleague Rachel Adams from the literature department, so this is a project that's funded by the Precision Medicine Society and the ISSD, Social Differences Department here at Columbia University. And this is an effort to bring into the medical conversations about precision medicine also humanist voices, lawyers, social sciences, and so forth, with the idea that medicine is not just about physicians, it's not just about medicine, it's about the interaction among many, many disciplines. And one of the projects that's actually not related to that project, but I'm particularly invested in, and I've led as the first national study on it, is disability and precision medicine research. And so I'll be happy as well to share some of these findings and share it with the audience and have a conversation about it.
Why don't we start there, and then we'll come back and talk about what you're finding in the Aspire studies. What are you finding with regard to precision medicine and people with disabilities?
Right. So let me just quickly step back to ensure that everyone sort of understands what's at stake. And when we think about the right to health, we think about what can we do now to be healthy, but also what societies or states have to do to ensure that people have access to whatever measures will make them more healthy. Mm-hmm. One aspect that we tend to forget is that it's not just about having access today to clinical settings, for example, and services, but also that if we're not included today in mainstream health research, we will not be able to reap and enjoy the benefits of that research in the future. So precision medicine research is exactly where we are looking at this, if you violate the right to inclusion in medical research today, you will have consequences on the right to health today and in the future. And that's where precision medicine is.
So there are really two, maybe 3 points here that I take away from this. One is people with disabilities are not being included in the research on precision medicine. As you know, I work on aging, and one of the fascinating things about research on older adults with mental health problems is they can't be in the studies if they also have physical health problems. Now, I don't know if you know an older adult who doesn't have a physical health problem, but it's ridiculous.
Right.
You can't get a finding that's meaningful there. The same thing here.
So one is it's relevant for all mainstream healthcare research, right? So it's not just about precision medicine. Anything that might interfere in the results, they exclude. And with people with disabilities, very often they are, one, perceived as lacking ability to give consent, even if they have their disability is simply using a wheelchair.
Right.
And two, they are excluded because of the concern that their disability or their impairment might interact with the clinical trials. With precision medicine research, of course, there is an effort to include them in some contexts. For example, if you do a study on deafness, you're likely to include people who are deaf, right? However, precision medicine really offers more than that. It offers to be able to tailor, for example, cancer treatment to people with a variety of other conditions. But if deaf people will not be included in studies about precision medicine research and how that can improve treatment of cancer patients who are also deaf, then they won't enjoy the benefits.
It's a really serious and important issue, no doubt. I mean, your other point, I think, is that this is the future of medicine, or a future of medicine, but it's a very important future of medicine. And if we don't get the research right now, the populations that are left out of the research will be left out of the benefits of this going forward. Something we want to come back to.
And I just want to add that, of course, racial and ethnic minorities have historically been underrepresented in health research, and including precision medicine research. There's been a lot of efforts to include them now and engage with them in order to bring them into this type of research. People with disabilities are a second level of people who, if you have a disability and you're from African American community, you're twice as likely to be excluded. You're not going to be part of it. If you are LGBT or Native American, women, you're 3 levels discriminated. And again, the health disparities are just going to increase if we're not going to ensure that they're included.
So we should come back and talk more about health disparities. I do want to talk about the refugees and what you're finding with them.
Yeah, I mean, I can also piggyback off of this just in terms of my own research and some of the research that's been happening here at the School of Social Work and the Social Intervention Group. We also follow a similar idea in terms of layered vulnerabilities to an extent. To me, that's a lot of what you're saying. So in the Social Intervention Group, we work with substance-using populations, for example, and right now one of the things I'm looking at, in addition to the refugee work, is thinking about sexual and reproductive health care for those populations.
Say that again. I missed the words.
Sexual and reproductive health issues and care for women who use drugs. It's another layer of vulnerability. These are all additional. And then, of course, there's a proportion of that population who are disabled as well, right? So making sure we're adding in these the appropriate tailoring, I think, is very important and multidisciplinary, as it should be.
But you're finding, as I recall, in your work with refugees, that women are more vulnerable to poor health care.
Yeah. So to bring it to the refugee work, so we have we've thought about a couple of things. So if I speak particularly about our study in Jordan, so this is a study with over 500 women who are Syrian refugees living in non-camp settings in all parts of Jordan. One of the biggest pieces we've seen in terms of healthcare access and utilization, in terms of barriers, over 90% reported that cost was the biggest barrier to accessing healthcare resources. And there are a lot of reasons behind that, and we'll go into that. I can go into it now. We're going to spend a lot of time on Thursday talking about that.
But I'm very surprised by that, because it may be I have a total misimpression of what it's like to be a refugee in Jordan. I'm surprised that the biggest problem isn't the lack of health care.
So
So you're saying the biggest problem is paying for it, but it's actually there and it's available to people who can pay for it?
So there are different, so to answer that question, we'd have to go into a little bit more of understanding health systems,
Okay.
right, in each country. So specifically if we're talking about Jordan actually has a pretty strong health infrastructure, right? So in terms of refugee response, there's government of Jordan that has Ministry of Health clinics, and there are services that are available to refugees and vulnerable Jordanians and Jordanians in general at those clinics. Ministry of Health services are the most comprehensive and high quality services, especially for reproductive health and maternal and child health services. That is where refugees want to go. There's a cost that refugees have to pay in order to access those services. Simultaneously, through the UN Agency on Refugees, UNHCR, they also offer funding to non-governmental organizations to provide comprehensive,
Right.
as comprehensive as possible, services to refugees. So our partners, where we did our projects, were with the International Rescue Committee, Institute for Family Health. These are phenomenal NGOs providing health services specifically to refugees. That is free of cost. But I believe it really does come down to comprehensive and high quality care, especially when it comes to maternal and child health care. Delivery, those services, those need to take place because of systems and because of funding within those Ministry of Health clinics.
So there is a cost issue. There's also an availability issue, though you're saying in Jordan
To an
it's
extent,
less
yes.
than it might be elsewhere, but there's also a quality issue.
Quality is very, very important. And that I think is true for settings across the world and in the US as well. And I want to highlight that as reproductive health clinics are closing throughout the US right now. I think it's really important to not just think about this in low resource settings in developing countries or humanitarian settings. We've got these issues here for sure.
Well, that's interesting.
I actually want
Go
to
ahead.
add something about the cost. The costs that are associated with healthcare are, to begin with, very burdensome for many. But if you look into the disability community, for example, there was a World Report on disability in 2011, and found that it's not just lack of access to services that are a problem or the cost that are too costly, but that there's also the costs that are associated with everything around it. For example, transportation,
Exactly.
health insurance, childcare. All of these issues that prevent you eventually from coming to receive healthcare services. In our study on disability inclusion in precision medicine research, which I'd like to share a little bit, because it is a first effort to really hear the voices of people with disabilities about, do they want to be involved in that, and what are the barriers that they might experience in that type of involvement. We enrolled almost 1,300 people with disabilities around the country.
This country.
Yep,
United
the U.S.,
States.
Okay.
not Jordan,
Okay.
not,
Exactly.
U.S., the
Yeah.
U.S. And we found a significant high number of people who said they would like to be part of it. 89% said that they want to be part of a precision medicine research initiative. In fact, it's much higher than the general population. But when you look into asking them, so what are the barriers for your participation? We gave them a list. And we found that 76% have between 3 to 8 barriers to participation. 3 to 8 barriers to participation. And that includes problems with transportation costs, clinical facilities that are inaccessible, professionals who do not know our needs. There's stigma concerns, stereotypes, all of these issues that make people resentful or concerned or reluctant to take part in this type of research because they have to cross so many barriers to be included. And again, if you think about it from a human rights approach, the point of it is once you have to pass through so many barriers, you stand back and you're like, why would I try? The whole idea of human rights is that we should be having equal access to these opportunities. We should not be struggling in each step of it. And again, our disability study is illuminative in that obviously they haven't been invited to participate in precision medicine at that point, but they have experienced health disparities and the challenges that they have when accessing care.
So let's we don't have all that much time before we start taking questions. In fact, we already have one up there. But let me push a little bit further before we take a question. The things that you're outlining are entirely familiar to me because I work in mental health advocacy, and the problem of access is a central problem. I usually say there are problems of capacity, problems of access, and problems of quality, and those are the three major things that we need to address. But here with the population of people with disabilities or women, they're not getting access to what they need. What do we need to do to fix this? To change this, to make it better?
So, there are a few things that I think have to be changed. One is, of course, environments. We've got to start rethinking how environments are inclusive. Do we use universal design? Do we use facilities that are accessible? That's costly, and I understand that it takes the time, even though we have the Americans with Disabilities Act that requires that. I think one of the other areas that came across very strongly for us is the lack of health providers and researchers knowledge of the needs of people with disabilities. For me, that calls into question, what do we learn? How can we ensure that those who are doing this type of research, and it is an important research, and healthcare research more generally, how do we ensure that they understand what accessibility means? That they're aware of what accessibility measures exist, that they learn how to create accessible surveys and material for studies that people with disabilities will be able to participate in.
Let me just interrupt there, because we do have to get to the questions. I just want to give Anindita a chance on this as well. Is there anything that you'd add to that?
Yeah. I mean, I agree with everything that you're saying in terms of application to vulnerable populations of women. I would just add, really thinking about when we're talking about women, abled or disabled, all vulnerable populations, really considering the gendered context and the gendered inequities that drive barriers to healthcare in general. So everything from issues of gender-based violence, sexual violence, discrimination, and then thinking about these
And just quickly, by gender-based, you mean not just towards women, but also?
To anybody who identifies as female. So this is inclusive of the LGBT community as well. But the concept is that the discrimination against women or the
There's
violence
a whole conceptual framework here.
Is based in identification of being female.
Okay, so let's take a question for Dr. Sabatello. Did the study of precision medicine arise as a response to a particular case, situation, or dilemma? Would like to know a bit of the history.
So, well, of course, the history of people with disabilities and medicine, and especially genetic research, has been very, very controversial. We don't have to go all the way to World War II to see how they've been trying to kill anyone who was not what everyone thought should be, how people should be. So there has been a lot of contested area here about use of genetic information in prenatal testing, for example, leading to abortions and so forth. Precision medicine offers something that's supposed to be more comprehensive in that it includes, again, not just genetics, but also what is otherwise social determinants of health, lifestyle choices, right? Yeah. So it's supposed to be much more comprehensive. My gut's feeling of looking into this particular group was exactly because it is the largest health disparity groups in the United States. Wow. And when we look into studies today, we never collect demographic data about ability or disability. And so when you look into studies, you have patients, but not all people with disabilities are patients. You have about women, you've got about race, but you don't have about disability. So for me, that was a group that is really missing from the conversation, and yet it's about 20 to 25% of the U.S. population. This is a large group to ignore.
I was going to ask that. So you're saying 20 to 25% of the population. There are different definitions of disability in the United States, as you know. So we've got Social Security disability has one, SSI is almost the same. Then you've got the one used in the American Community Survey or whatever it is. So in one it says there are about 9 million disabled people, another one says there are 60 million disabled people. Where are you in this spectrum of disability?
I looked into the American Survey. You know, for me that was one of the documents. And for our study, we requested participants to self-identify.
Uh-huh.
I do not want to go with categories. People have to feel for themselves what they feel in the same way that we're doing now with gender, right? We're not
Exactly.
coming
Oh,
with a
interesting.
decision about
Very interesting.
are you male or female.
Exactly.
We have increasingly other options.
Yes, as we should.
And as we should, obviously. So, and we have also with racial categories. We
Yes.
don't have black, whites, and that's it. We've got multiple identities. So that's where it comes from.
Well, we sometimes have multiple identities, and
I think we all have multiple identities in every given
Or facets.
in every
Yes.
in every
Yes.
in
in
every
every
study.
individual. Well,
I
you're
look
a
at
man,
studies.
you're a professional. I don't know if you're a family member.
Yeah, but that's not all getting reflected in a study in which I would be included as an old person with, say,
It
high
would.
blood pressure.
It would, in terms of looking at your socioeconomic status, at whether age, and family support is one
Not
of the
my
main things
ethnicity.
that actually impact healthcare.
Okay. Well, all right. I don't want to get into
Yes.
an argument about that. I mean, I do believe that there's not enough differentiation of these kinds of variables, and I think it's very interesting what you were saying, that disability is just ignored in most of the regular studies, unless they're studies of people with disabilities, right?
Right. I have to say that the National Precision Medicine Research Initiative, which was launched by Obama in 2005, is actually now making effort to collect data about disability status. And that study was actually funded by this program, which is called the All of Us Research Program. So hopefully we're moving to the right direction,
Right.
but it's still not in the mindset of most researchers who are conducting health research.
Can I ask a follow-up
Yeah.
question? Is that
Please.
okay?
Yeah,
Sorry.
go right ahead.
So as a public health researcher who does a lot of data collection with different populations, mostly with women, on a regular basis, if I had to include a couple of questions, if you would look at my work and say, you should include these questions,
Right.
do you have a sense of what those would be? Maybe could it be as simple as 2 questions that we include
It could.
in every survey?
Yeah, you
Okay.
know, I would say
That's
the
great.
first question would be, do you self-identify as a person with disability? And then
Perfect.
you can go from there to say, if so, what type of disability? And you can either give some categories, or you can sort of broad categories, or leave it open. You know, so they can fill out, but then you can have a lot
Yeah.
of conditions. But you know, people self-identify, and
Yeah.
I would let them have that power to make the decision.
I think it's important though that we highlight also that it is just that simple too, because I think sometimes as researchers it's overwhelming to think about including as many populations as we can and taking into these accounts, but that is our job, right?
Right.
So I really like and appreciate this
Right.
sort of tip that maybe it could be as simple to
And
start with.
I would just add that one thing you might want to be considerate of is that, of course, not everyone who has a disability perceive it as a disability.
Right.
If you think about the deaf community, they don't see deafness as a disabling condition at all, as well as some of the neurodiversity movement,
Right.
Autistic folks. So I would think.
Psychiatric disability gets also quite complicated.
Yes,
So,
yeah.
so with deafness, people think of themselves now as a culture rather than as
Correct.
as
Ye-
disabled.
yes. And therefore, you have to use, I mean, what we've done here is really, in our study, we really use disability-friendly language. Do you have a disability?
All right, let's take another
condition?
question here,
Yeah.
because we're running out of time. Given all these barriers, what can social workers do to help people with disabilities access the health care that they need? Anybody? What can social workers do? Well,
Provide supports, first of all. I think learning about the various communities and how to communicate in ways that are not offensive. I mean, you know, anyone who is involved with the medical profession has a tendency to medicalize people with disabilities. One way is really to start treating them on the eye level. They are just equal. But it's also to learn how to reach out and help and offer supports in a way that is sensitive to their needs.
well, I always go first to the macro level, as we call it in social work these days, otherwise known as politics.
Right.
So I always go to the level of the first thing a social worker or anybody else can do is to advocate for changes in the healthcare system that would solve some of these problems of access. Paying for transportation,
Right.
making it convenient, having office hours that make sense. You know, I work in the field of mental health, where you've got people who are supposed to go to clinics between 9 and 5 days a
Right,
week.
exactly.
I mean,
Right.
this makes no sense.
No, especially-
And the system really has to be changed.
But I think we should all advocate for these changes.
Yes.
I do
And
too.
this is something we should all try to gain. I mean, this is one of the things that when you have healthcare and when you have health more generally, you are a much more productive person. That's the way it goes. But I think we really need to get more education. Education for me is to remind people about biases, about self-assessment of where their biases are, how we can change that, and work with personal encounters with people with a variety of disabilities.
Next
For sure.
question.
Yes.
Dr. Dasgupta, can you tell us a bit about how Aspire decided to focus on the needs of service providers?
That's a great question. So this is actually in relation to our study in Turkey, and I'm so glad somebody asked the question. So in Turkey, we have this incredible study that really focuses on the mental health of providers who give direct services to Syrian refugees. And it's such an interesting situation because we initially went in thinking we would do primary data collection with Syrian refugees in both Jordan and Turkey. And we found that our partners at agencies were just so overwhelmed with the immense caseload. And being at a school of social work and having the expertise in issues around secondary trauma and mental health, our group decided to really focus on the providers instead. So stay
This is
tuned.
a fascinating topic, and one of this. If you look, there have been some studies about the human costs of human rights
Exactly.
advocacy.
Exactly.
Right?
That's
And
exactly
this
the
is
lens.
exactly where it goes.
Yeah. And we have qualitative and quantitative for that study.
That's fantastic.
And our collaborators here from Turkey.
Next
so-
question.
Sorry.
No,
so
no,
excited.
it's good. This is great. We just need to keep it moving along here. Are Syrian refugee men in Jordan getting better health services than women? Or is the problem that women need... The teleprompter just disappeared.
More
Come
health
on back.
services.
Or is the problem that women need more health services than men because of their reproductive capacity?
So, in terms of participation in healthcare, it does differ. The data aren't great in terms of understanding participation in healthcare services right now. This is another topic, but data aren't very strong in this area.
Right.
But given the vast reproductive health needs of women, especially refugee women who have come in, we've really focused on those issues. So I would say that has been the
But
biggest
you're not
concern.
necessarily saying that it's worse for women than for men. You're saying women have
No, I don't-
particular issues with reproductive health
Yes, that
that men
compromise their
biologically
health.
don't have.
Yes,
so.
I believe that women have more reproductive health. They have reproductive health concerns that compromise the rest of their quality of life. So we're focusing on them. But I don't think we have enough data to really be able to say that it's worse off for women than men in terms of healthcare.
Do you
access
have
and
any
service.
sense among the refugee population of the outcomes for men as well as women? So what I have in mind is the recent literature here on deaths of despair, in which life expectancy in the United States is going down. At least one group of sociologists think it's because that is focused in a population
Right.
of men of working age with no more than a high school education, and that they are killing themselves, overdosing, and dying from alcohol-related death at a very high rate, much higher than women. So, I mean, I don't know, in a refugee
Right.
situation, do you have any sense of that?
The biggest challenge with working in a humanitarian context has really been accessing rigorous data and finding out information like that. So I mean, that type of data and that what you're describing, right? That's a very long process to really study.
And the people
over
you're working
time.
with, is war raging around them, or
well, the
are they
Syrian
fairly
conflict-
safe from war at the moment?
In Jordan, it's a pretty stable context. They did open the border to Syria during our study, and we'll talk a little bit more about that on Thursday. But Jordan itself is incredibly stable and safe. And,
I think
So,
one of the
so for
challenges
those
in
listening,
general-
just a second, Thursday there's going to be an interesting conversation about what happens with the Syrians coming into Jordan, right?
yeah, exactly.
So
I think the
go
lack
to the
of
program.
Data, the lack of
ahead.
data, I think that's exactly where we have it. We have no data for
Really
all of the
challenging.
vulnerable populations. So
Absolutely.
easy to get on white men.
Yes.
High socioeconomic status.
Funding to study this as well, right?
And then go and find information about those populations. There are also people with disabilities who are refugees, of
Exactly,
course,
exactly.
and we've got very little information that can that's collected on these groups.
Exactly, and God forbid we want to talk about reproductive
Right.
health for any of these populations.
Yes.
So.
Yeah.
So, what are your thoughts about changing the healthcare system in general, given your experiences? You're particularly concerned about women and their issues. You're particularly concerned about people with disabilities. You've said this is not just an issue in the developing world. We're talking about the developed world as well, and the United States included. Any sound bites about how you'd like to see the system changed in, say, this country in order to address these issues? You've given us a list, but, you know, there's a...
I have a one-liner.
Yeah, good. Well, let's have a
healthcare.
one-liner. That's
Yeah,
great.
I mean, it's universal
National
access, and it's, I mean,
Yeah,
for women,
universal
it's
access.
eliminating gender inequities
And eliminating bias.
And eliminating bias. Okay.
and getting them to intersect, right?
We just solved the world.
So-
Problems of the world.
So we're not going to have a debate about whether it should be Medicare for all or some other way
There's no
of
debate.
approaching this. Maybe we'll have a show on that another time. We do have one last question.
Good.
What qualitative data are particularly important?
Yeah. Do you,
Go right ahead.
Yeah, so the importance of having both quantitative and qualitative data, I think, are really important. Quantitative data gives you the broader perspective, prevalence, generalizability. Qualitative data are so important. They reflect the voices directly of the target population, and they also give you the context for the larger quantitative data. So I'm a big proponent of mixed methods research.
Yep, couldn't agree anymore. I think hearing the voices of the individuals who take the time and explain, because we have a tendency of interpreting results by our understanding of the question.
Right.
But participants might have understood the question completely different, and so that could be something very important to kind of hear that voice.
So I think that's a good note to end on, the importance of actually talking with and listening to the people who are affected by the problems that we're dealing with, whatever kinds of problems those are. And it is, of course, quite common for those of us who are in professional positions to impose our understanding on the people that we're supposed to be helping. And we often miss an awful lot. So getting those voices, hearing those voices, and I would add, often not interpreting the voices.
Right. Right. I'll also just say that we do have a conference coming up tomorrow and on Thursday. It's a conference by the Precision Medicine Society and focuses on precision medicine and its impact on patients, providers, and public health.
Wow.
And how can people get there?
Go to the link. There's
Are we posting
just
a link,
Google
I
it.
hope?
We
We're
will,
posting a
yes,
link.
we're
Okay,
posting
there's
a
a
link.
link right here.
And it should be very interesting. Again, hearing about this issue from different perspectives.
So a lot happening this week. You have a
Yes.
conference for the next 2 days. You've got an event
get it
on
together.
Thursday.
Exactly.
And I'm glad the two of you had this opportunity to
Yeah,
meet,
this is
and
fantastic.
maybe you
Really
can
appreciate
carry
it.
this
Yeah,
forward in
absolutely.
the
I look
university.
forward to
Yeah.
that.
I want to
Had
thank
questions.
everybody who has tuned in today. We hope that it's been a great show, I think, and very good guests. I'm glad that you were here. Thank you very much. Next week, we're going to have Jane Waldfogel from the School of Social Work, and she is an expert on poverty. And next week, she's going to be talking about something she recently testified before Congress about, how to level the playing field for working families. So we should have an interesting conversation. We hope you'll tune in. Thank you very much.
Thank you
Thank you
you.
very much.
Thank
you.
you.
Nice to meet you.
Nice to meet you.